On the 2025 Clinical Coding Interview Standards. If you're getting ready to step into this job market, you really need to know that the whole landscape has changed. I mean, we're not just talking about passing a test anymore.
That's exactly it. That's the mission here. The job of a coder has, it's shifted. It's not about volume-based data entry anymore. It's become a core part of a value-based revenue cycle strategy.
So employers, they're not looking for technicians. They want auditors, critical thinkers.
And you can see that shift right away when interviewers bring up technology. We've seen it so many times. A candidate talks about computer-assisted coding or SAC, like it's a huge threat to their job.
Yes.
But framing AI as this, scary competitor, that's actually a massive red flag for them. Why is that view so outdated now?
Because the role has been elevated, not eliminated. Look, the CAC handles the low-hanging fruit, all the straightforward cases.
The easy stuff. Exactly. The human coder is now the high-level validator, the auditor. You're focused on the complex cases, on medical necessity, and this is key. You're correcting the machine.
So you're actually training the AI.
You are literally training the AI model to get smarter. So interviewers, they want to see that you're focused on precision, not that you're driven by fear.
And speaking of that precision, what about remote work? For anyone going for a remote job, interviewers are basically auditing your home office setup.
They are.
That responsibility now extends way outside the hospital firewall. You have to be able to detail your HIPAA, adherence secure, VPNs, privacy screens, everything to protect that patient health information.
If you can't articulate those compliance details, you won't pass the interview. It's that simple.
Okay, so that auditor mindset, where does that lead us next?
It leads us directly into the most frequent technical traps.
Yeah.
Specifically, modifiers. They are the source of just massive audit losses for health systems. And we've seen a really big shift away from the old and frankly overused Modifier 59, the one for a distinct procedural service.
Right. So to get into the technical meat of it, Medicare really cracked down. They brought in that whole suite of X modifiers to force more specificity.
Exactly.
Like, you have to know the difference between XS, which is for a service on a separate structure, a totally different part of the body, versus XE, which means it happened in a separate encounter on the same day.
And they're not interchangeable. Not at all.
I see.
And that demand for specificity, it flows right into evaluation and management coding. EM, the foundation now is either medical decision-making, MDM, or time.
And there's a really subtle trap with time, isn't there?
A huge one. It catches so many people. When you're coding based on time, only the time spent by the provider on the date of the encounter actually counts.
Okay, so if a doctor spends an hour finishing up the chart the next morning,
that time is gone. You cannot use it to bump up the EM level.
Oh, yeah.
It didn't happen on the encounter day. Understanding that cutoff is what separates a technician from a true compliance expert.
All right, we have to talk about the highest stakes diagnosis, the one that gets audited constantly in the inpatient world. Sepsis.
Oh, yes. If you don't know the ICD-10-CM golden rule for sequencing sepsis, you're creating a massive financial and compliance risk for your employer.
So what's that clear hierarchy? What do candidates absolutely have to be able to explain?
It's all about timing and the definition of a printable diagnosis. So scenario one, sepsis is confirmed, present on admission POA, and it's the reason they're in the hospital. In that case, the systemic infection gets sequenced first. Simple enough.
But what's the other scenario, the one that's the trap?
The trap is when the patient is admitted for a localized problem, let's say a UTI, and then sepsis develops after they're already admitted.
Oh, okay.
In that case, the localized infection, the UTI, remains the principal diagnosis. If you code sepsis first, you are falsely inflating the DRG. That is a critical audit failure. And you see, this is all about strategic thinking. The interview is a test of that. You have to be able to differentiate the stakes.
You mean like the difference between fraud and abuse?
Precisely. You have to be able to clearly separate fraud, which is intentional deception like knowingly upcoding, from abuse, which is more like improper practices from, say, negligence or just not knowing the rules.
Both are bad, but the intent is totally different.
And then penalties reflect that.
And you show that strategic ethical thinking with how you write a query to a physician, the non-leading query.
The only way to do it.
Your goal is always audit-proof documentation. So you don't ask, hey, doc, can you please document sepsis?
Never.
Instead, you present the clinical evidence you found. Patient documentation shows a lactate of 4.0 and systolic BP of 80/50, and then you simply ask for their clinical interpretation of those facts.
Yes, let them connect the dots.
And that's how you show you're an indispensable defense against federal audits like the ones from the OIG work plan. That's the knowledge you need to take with you.